Welcome to session 2 of our series on oxygen therapy and critical care, the case-based series. Our host is Dr. Xavier. Before we commence, if you have any issues, kindly use the chat box. And then this program is in partnership with Assist International, ECHO India, Stanford Medicine and Division of Anesthesia, and then the LRC is where our resources taken from. So please, I would have Dr. Veva kindly introduce his co-panelists to us.
Hello.
Yes, thank you.
Hello.
My team is with Dr. Uimana Francois Xavier, working at Nyarugenge Hospital, COVID National Referral Center. On the panel, we are having Rumagiwa Liberata, is a lecturer nurse at University of Rwanda, College of Medicine as a Health Sciences. We are also having Dr. Niyonzima Joseph, is an emergency and critical care specialist at CHUB, that's is a university teaching hospital of Butare. We are also having on the panel Dr. Hundimana Venus, is a specialist in internal medicine, working at the Kibuye Referral Hospital, COVID-19 wing. We're also having Mani Rafasha Podner, is an emergency and critical care specialist at the King Faisal Hospital. Today is our second session. Among the 12 sessions we will be going to attend, we will be talking about diagnosing hypoxemia with the pulse oximeter. So as people are still coming in our room, please, we can continue our presentation. As I said, our second session talking about diagnosing hypoxemia with pulse oximeter. The contents of this session has been adapted from Global Anesthesia and Critical Care Running Resource Center. We are, next please, we are in a partnership with Project ECHO, Assist International, and also Stanford Anesthesia Division of Global Health Equity. And today, as we say, we are going to talk about diagnosing hypoxemia with pulse oximeter. You remember last time we talked about considerations of triage. Now with your triage today, how do you detect hypoxemia by using pulse oximeter, and what is next? As usual, our talking are also case-based learning. We have a case, we discuss about it, and we go through it, how we diagnose, how we manage, and what's the next in the planning. Next, please. The case is our continuing case. As last time we had this case coming to our emergency departments, and then the triage has been done, let alone has been isolated in isolation room. And during that isolation room, the patient has been taken in the room, and then new vitals has been taken. But the patient presented or expressed the shortness of breathing, with moving and eating, and also has been less active on the bed. The question to answer on this is, how do you know the patient is hypoxic? And once you know the patient is hypoxic and you start him on oxygen, so when you know the time to increase the oxygen, escalate, or the time to escalate oxygen, the therapy support you are providing. These are three main questions we are going to discuss through this case discussion. By objectives of our today's session are, as we said, based on this hypoxemia with pulse oximeter. Next, please. So the learning objectives today are, can I say, into two parts. Part one is hypoxemia with pulse oximetry. The second part is hypoxemia also with oxygen therapy. So once you know the patient is hypoxemic by pulse oximeter, you have to give also oxygen according to what we will be discussing. To the part one objectives, we have to understand how to use a pulse oximetry correctly and appropriately, and also how to interpret data from pulse oximetry, but also while understanding the latency and the limitation of the machine you are using. And the third, we have to understand the conditions that may interfere with the pulse oximetry accuracy. Not always every reading in the pulse oximeter is that exact condition the patient is in, but also know how to clean and maintain the pulse oximeter device for the next to be used. On the second part, I want you as a session that the session attendees to be able to select and rank oxygen delivery devices by FiO2 delivered by each of them. As we said in the case discussion, when you know to escalate or to escalate the oxygen therapy you are providing. The other thing, and very important, is here is a triage tool called LifeBox, LifeBox triage tool to help you select the most appropriate oxygen delivery device and also know how to titrate the oxygen. When I mean titrate, is meaning up and down the oxygen you are providing. We will end up by having kind of skills assessment or skills to you as audience, where you are working in different hospitals, to be able to go and assess your facilities, non-invasive oxygen delivery devices, and also go back and assess different types of oxygen sources or oxygen supply which are available and ready to be used once our patients will need in this pandemic of COVID-19. And next, please. You will allow me to invite Dr. Venus with Dr. Apollinaire to talk about how do we know that patient is hypoxemic, and then how will we appropriately treat the patient who is hypoxemic by the next factor that will help us to know the patient is hypoxemic. Up to you, Dr. Venus. And after each presenter, please the audience be ready for some questions to ask him for clarity and clarification. And you want this course to be so interactive and friendly as we can. Thank you, Dr. Venus.
Thank you very much, Dr. Xavier, for the nice introduction. I hope that everyone is hearing me clearly.
Yes,
is it the
thank
case?
you. Yes, very clear.
All right. I'm Dr. Hundimana Venus. As said, I'm a general physician at Kiwi Referral Hospital. So today it's my pleasure to be with you in the second session of the Oxygen Therapy and Critical Care Hub. I will share with you the first part of today's activity, and I will address the first 4 objectives. So at the end of my presentation, the participants will have knowledge on the use of pulse oximeter. They will understand what is pulse oximeter latency or lag, and they will also understand the interpretation of pulse oximeter data that we read on the monitor. And then we shall see how we may clean and maintain pulse oximeters. So in the previous session, we have seen the difference between hypoxemia and hypoxia. The hypoxemia being the low level content of oxygen in the arterial blood, while the hypoxia is at the level of body tissues. So a lot of conditions can cause hypoxemia, and the hypoxemia subsequently can lead to hypoxia. So one of them is high altitude. As you elevate, the atmospheric pressure decreases and your oxygen level in the blood might decrease. So hypoventilation as well can cause hypoxemia, diffusion impairment, ventilation perfusion mismatch, as we have seen in the previous session of the pulmonary physiology, but also shunting in the conditions where alveoli are filled with fluids and parts of the lungs are perfused, but they are not well ventilated. So like pneumonia or conditions causing pulmonary edema. So we can have other causes of hypoxia, but it's not the main topic of today. So today we are reviewing the hypoxia, how to diagnose it using pulse oximetry. So there are clinical signs of hypoxemia that you can see on the patient. They are abbreviated in this acronym if you want to use the mnemonic: rat on bed. That being rest, the R for restlessness, A for anxiety or anxious patient, and T for tachycardia or tachypnea. So for the rat, they are the early signs, but in the red signs, when the hypoxemia has lasted long, a patient can have extreme case of breathlessness, and the patient can have bradycardia. They may appear cyanotic. So we shall see how the pulse oximeter can warn the healthcare providers regarding the existence or the presence of hypoxia in the early stage. So we can also rely on the arterial blood gas to detect the hypoxemia, but generally in the emergency department, in the pre-hospital settings, ICU settings, the pulse oximetry is the one we commonly use to detect someone's oxygen saturation, abbreviated as SpO2. Next slide, please. All right, this is almost what we talked on the previous slide, but there is last sentence saying that not always the clinical signs are not always present in COVID patients. So for people who have been working in the COVID treatment centers or who have been reviewing patients at the triage settings, you have seen that most of the patients who are having COVID-19, the degree of signs doesn't correlate with the degree of hypoxemia or hypoxia. So like at 75% on Romea, patients may be able to talk with complete sentences, which is not the case in the usual pneumonias, like bacterial pneumonia. So you have to rely on this quick tool, which is the pulse oximeter, to detect earlier the hypoxemia in patients with COVID-19. Next slide, please. On this slide, you are seeing the different devices, the pulse oximeters we use to detect the hypoxemia. And the pulse oximetry, generally, it's a quick, non-invasive method we use to measure patient hemoglobin saturation by using the right signal transmitted through the screen. We shall not go into the physics around the function of the pulse oximetry, but we will try to summarize the basic principles. So generally, the pulse oximeter has two main parts, and one is the monitor, which contains the batteries and the screen to display the readings of the pulse oximeter, which is the pulse and the oxygen saturation. So we also have the probe that senses the pulse of the patient. Next slide. Yes. So the oxygen saturation is the main reading we see on the monitor of the pulse oximeter, and you can classify your patient if they either have mild normal saturation or normal values. You can detect the hypoxemia level if it is mild, moderate, or severe. But you also record the pulse rate, which is calculated by the machine using average of between 5 to 20 seconds. So you can also have a wave curve on the monitor, which is going to display the strength of the pulse, and the shape of this wave will also correlate with the quality of the pulse. So you are seeing a graph showing red and infrared, and you also have on the horizontal line methemoglobin, oxyhemoglobin, and reduced hemoglobin, or carboxyhemoglobin very down. So the key message in this graph is that usually on the pulse oximeter, so we are measuring how the the hemoglobin containing oxygen and the deoxygenated hemoglobin absorb the light to when it is penetrating the skin. So you can see on the red band, so reduced hemoglobin will absorb more light, while the oxyhemoglobin will absorb less light in the red band. On the contrary, in the infrared band, the oxyhemoglobin will absorb more light than reduced hemoglobin. So when the machine, the pulse oximeter is giving the values of the saturation, it's the ratio of absorption of the light in the red and infrared bands. Next slide. So we can go to the next slide. So now we are approaching the practical use of the pulse oximeters. So generally you have to select the appropriate probe with a particular attention to the size and where you want to place the probe. If it's either the finger or the toe or the tip of the ear, but it also depends on the size of the patient. Like in the neonates, the probe for the neonate might differ from the probe for adults. So then you have to connect the probe on the pulse oximeter, then turn the pulse oximeter on so that it can start to do calibration internally. Then you position the probe carefully by making sure it's easily fitting on the patient's toe or finger or tip of the ear. It doesn't have to be too loose or too tight to cause compressions. So you also have to avoid the alarm, the being used, it's not the arm, sorry for the typing error, it's the alarm used for blood pressure monitoring because it can interfere when the cuff inflation is being inflated, it can interrupt the pulse oximeter signal. Next slide. Then after connecting your probe to extremity part of your patient, you have to allow few seconds for pulse oximeter to detect the pulse and do the calculation for the oxygen saturation. Then you have to look on your monitor the pulse indicator, which is the pulse wave, and you have to see the numbers. And whenever there is no pulse detected, the readings are not accurate. Here, the common scenarios are when you are attending a CPR session where a patient is receiving chest compressions. Sometimes you get the readings of oxygen saturation, but the signal of the pulse is absent. So you don't have to confirm that the saturation reading you are seeing on the screen or the monitor is accurate, as long as the pulse signal is not there. So like in all the machines or electronic devices, the oximeters, they can have occasionally give false readings. And when you're adapting, you have to use your judgment. Like if you adapt the malfunction of the pulse oximeter, you can test on your own finger. Next slide, please. So regarding the pulse oximeter data interpretation, so you have to properly position the probe to have normal readings. Otherwise, you can have false results. If the signal obtained, if there is no signal obtained on the pulse oximeter, you have to double check if it is well positioned or if it's not due to the poor perfusion of the patient's extremities. And in this setting, you need to check the blood pressure, and if you record low blood pressure or the patient is hypotensive, you have to start resuscitation by giving boluses. Then the parameters will get corrected, or you can try to rub the patient's extremity to trying to warm them so that you can have normal readings. So on the graphs you are seeing, you can see how the normal pulse signal will appear if it is absent in cardiac arrest or poor perfusion, or if there are noise interference, you can see how you can have a busy wave which is not accurate. When the patient is shivering or is shaking or being agitated, you can see those motion artifacts on the screen. Next slide, please. All right, for the pulse oximetry readings interpretation. Generally, patients with normal saturation, it's between 95 and 100%. Between 90 to 95 being considered to low hypoxemia or acceptable in certain circumstances. The saturation between 87 to 90% being the ranges where you are concerned for dangers for your patients, and you try to look for what might be the cause and address it. Next slide. So regarding the advantages of the pulse oximetry, pulse oximeters are incredible basic tools that are very simple to use, and they are non-invasive, and they are ready to be used whenever the batteries are charged. So you don't need to do any warm-up to start using the pulse oximeters. So they provide readings in the first frame, and they are cost-effective if you compare to arterial blood gases or other tools you can use to detect hypoxemia. So they also have certain limitations, like in a patient who are shivering or agitated, you may lose the quality of pulse, and the readings are not going to be accurate. So in patients who are poorly perfused, so you may lose the pulse and the readings on your pulse oximeters. So you have to be careful when you are evaluating the pulse oximeter readings in patients who are like in septic shock, who are having hypovolemic shock or other types of shock. So patients with arrhythmias can also have inaccurate readings depending on their qualities of the pulse. I think I've lost the slides.
Can you see it or not? Finished?
Yes, I'm able to see the slides now. Okay. Thank you. Next slide, please. Yes, now we are going to see one of the other objectives of our session, which is understanding of the pulse oximetry latency or lag. And this is a situation where you are using these digital probes for recording the saturation and the pulse using the pulse oximeters. So in conditions where the patient is having like peripheral vasoconstrictions, so this probe may delay to get the signal of the real numbers of oxygen saturation, like in settings where you are intubating your patient and you see in the monitor or the screen that the patient is desaturating. So it may be a false perception, concluding that maybe you have misplaced the endotracheal tube and extubate the patient, while the pulse oximeter has delayed to pick the real the signal to give the number for the saturation. So in this scenario, what is recommended is to try to pre-oxygenate your patient while you are going to intubate. And once you have pressed in the endotracheal tube, in the first 120 seconds, 120 seconds, when the saturation is down, you cannot conclude that you have failed your intubation. You just have to calm down and try to use the capnography, which will give you the amount of or partial pressure of CO2 the patient is blowing out during the briefs, other than concluding that your intubation have failed. I think this is very crucial in emergency situations where you may lose your paralyzed patient ready to be intubated or already intubated, and you remove the endotracheal tube and do multiple trials while you have to be patient and wait for like more than 120 seconds to have normal readings of saturation. So beyond the 120 seconds after the placement of the tube, if the saturation is down, that's where you can start to see what might be the abnormality and address it. Next slide. So there are certain conditions that can interfere with the pulse oximetry reading accuracy, and one of the factors is the light, like the bright light, like when you are opening the theater lights or the sunlight directly on the probe, they may affect the readings. So you have to pay attention. And when the patient is shivering, we have seen the quality of the signal detected is not going to be good. And the pulse volume as well, especially in patients who are hemodynamically unstable, who are very hypotensive or in shock. Next slide. In case of vasoconstriction as well, the blood flow to the peripheries is going to decrease, and the pulse oximeter may fail to detect the signal when the patient is very cold. So previously I said you can either correct the shock if it is there, or you can try to warm your patient by simple rubbing of that extremity and try to see if it detects the signal, which will allow you to get the readings. So in a condition where patients like who have like inhalational burn injuries, where they inhaled carbon monoxide, so you can get a falsely high saturation readings because the the carbon monoxide will bind to hemoglobin and displace oxygen to give the bright red compound called the carboxyhemoglobin. So you have to pay attention. So in different types of dysrhythmia also, you may get the pulse of poor quality and get the false readings of oxygen saturation. Next slide, please. So the last part of this first part of the presentation, it's about the cleaning and maintenance of pulse oximeters, because you don't want them to get damaged or be the means of spreading the infections. You have to clean them, and avoid any possible damage. So you have to do like an inspection of the exterior part of the equipment to see if anything is damaged or something is missing. Then you have to inspect the power cord if it is normal, and if there are signs of damage, you can replace them. So you have to turn off the unit, unplug, and open user accessible covers and inspect the unit, the whole unit, to see if there is anything damaged. So whenever they are not in use, you can plug the batteries to charge so that they are ready to be used in the next time. So you have to clean the interior components and the exterior components with compressed air, and inspect interior for signs of corrosion or missing hardwares. If something is missing, you have to call the maintenance team in the hospital to help you manage. So you also have to inspect the electrical components for signs of excessive heat or deterioration. If the probes are disposable, you can replace them, and verify if the machine can run online power without the batteries. So you plug them and see if they can function without inserting the batteries. Next slide. So we are going to see the videos on how you use or place the pulse oximeters and how you clean them and maintain to avoid the damage. Thank you very much. So your questions can be typed in the chat box, or you will get time to ask them anytime after this first part. Thank you very much.
Between patients, it is essential that you gently clean the probe and cord with medical alcohol. Small amounts of 70% alcohol-based hand rub will also work, but should be applied sparingly. It's important to keep the LED and photodetector clean. Please also remember to wash your hands, following proper protocol between patients. The oximeter should be wiped down regularly, using common detergent and non-corrosive disinfectant, such as those used in hospitals. Be aware that many kinds of detergents must be diluted prior to use. The oximeter case and screen can be wiped with a lint-free soft cloth or a sponge moistened in detergent. While cleaning the oximeter, be careful not to spill liquid onto the instrument, and do not allow any liquid to spill inside the oximeter. When wiping the side panel of the oximeter, be especially careful to keep liquid away from the cable and the outlet.
Do we share the second one immediately? Dr. Zaiva. Hello.
Sorry, I was talking muted.
Okay. Are we? Do you want us to? Okay.
No, the first video is enough. The first video is enough how to clean our pulse oximeters, which we are using routinely in our practices. The second is just the same as the talk we had from Dr. Venist. So to this time is time of question to the presenters. There is Dr. Venist, also there's Dr. Apollinaire on his backup. But generally from this presentation, please, you have to know 3 ways to detect hypoxemia by clinical presentation. That rat in a bed, you saw how it's really showing. Secondly, the blood gases, arterial blood gases, which is invasive and expensive, which I think not most of our hospitals or health facilities have the capacity to do blood gases. The third, and the routinely used, the pulse oximetry, which we need you to master. And by mastering this pulse oximetry, please know how to use it, know how to work, as Dr. Venist emphasized on. and you know how to do data interpretation by considering the probe placements, by considering also you remove all artifacts created from the artificial and the polished nails. Our patients currently may receive them with these polished nails or artificial nails. What will we do? So you take consideration of all those things while you are doing your data interpretation, and also remember the screen displaying the pass rate, the SpO2, and also the pass wave. This is a clear message before you read and report the saturation you are reading, and you know which saturation is normal versus abnormal saturation, and you consider this interference from vasoconstriction or poor perfusion, lights, shivering, and you know how you manage any case of shivering. You calm the patient, or also you hold the finger where you put your pulse oximeter, but also this CO2 toxicity, and then know how to clean for the next use. So this is time to your audience to ask some questions. And I hope from now, by using the pulse oximeter, you are not going to report. Recently, I have been transferred the patient saying that it's saturating at 60% on high flow oxygen. But on arrival here, it was just a misreading of the pulse oximeter. The patient was saturating at 100%, more than I have this time. So please, I want you to be familiar with these pulse oximetry practices, not just reading the numbers, but take into consideration all the things Dr. Venice have talked to us. Question, please, if you want, to Dr. Venice and Dr. Pollinaire, who are here.
So maybe no question.
If no question, then let's the audience, as we said, you detected that patient has hypoxemia, and also after having this hypoxemia, you have to know next to do is to give oxygen. How much, for how long? Let us, Dr. Joseph, introduce us and have a talk to this. We hope from knowing how to diagnose hypoxemia by using a pulse oximeter, we will know now how to treat by using oxygen therapy without wasting oxygen resources we have. So far, please, what Dr. Joseph is going to tell us about oxygen therapy on hypoxemia. Welcome, Dr. Joseph.
So thank you very much, Dr. Savi and the team. Of course, as you said, I'm Dr. Joseph, an emergency specialist at Sashibe. Of course, you brought your patient, which was hypoxic because of COVID-19 suspicion, was hypoxic, and then was put on oxygen. So now let's go through how that oxygen will reach your patient. So in this presentation, everyone will be familiar with oxygen therapy, titration for decision making. Then at the end, everyone will be able to choose the appropriate device for oxygen use. So let's start by the oxygen therapy and the titration decision making tool. So let's go on the next slide, please. Next. Can we get the next, please? Okay, thank you. So at this stage, as I said before, oxygen therapy and titration decision-making tool. So this is called LifeBox Triage tool. So this one, it is a rapid assessment tool which helps to triage patients or people who need an initial medical support or medical intervention. So this one was initiated, developed in the case of sorry, COVID-19 response. You know, this one was a pandemic and it was a serious condition. So this one, it helps all frontline healthcare providers to decide on the patient support based on the pulse oximetry result. So first of all, this tool, before using it, you have to ask your patient if he or she has the following symptoms. You see fever, cough, respiratory distress, or increased respiratory rate, depend on the age group. We have adult, children, and others. Then also, we ask if there are any emergency signs like shock, cyanosis, bradycardia, like that. So then, if the patient is having those symptoms, you ask to check his SpO2 by using a pulse oximetry. So if there is an emergency sign, as I told that, you put a patient on oxygen. If the patient doesn't have those symptoms, it means no symptoms. You assess your patient and you treat him based on your hospital protocol. It means you can put the patient in isolation if you suspect for COVID or protocol of other diseases. So for your patient, if you got a SpO2 and is above 94% without emergency sign, it's the same. You will assess your patient and treat him according to your hospital protocol. If your patient is having below 94% of oxygen or has some emergency signs, you will give oxygen starting by a nasal cannula. The idea here is to keep the SpO2 above 90%. If the patient SpO2 is above 90% without any emergency sign, you will manage your patient, of course, according to our hospital protocol. Then you see this third stage, when your patient is having SpO2 below 90%, it means your patient is hypoxic, or your patient is having emergency sign. Of course, you will increase the oxygen. Remember, on the previous step, you put your patient on oxygen. After putting him on oxygen and still hypoxic, you will increase your oxygen. Then if your patient deteriorates or continue to have hypoxia, so you will consider an admission to ICU or HDU. Of course, if you don't have an ICU, you will admit your patient in the ward where he will get the maximum respiratory support. Of course, for example, if you are in a DH and you did everything for our patient to increase the SpO2 and it's not moving, it's still below 90%, you will maximize your respiratory support. Of course, if possible, that patient will be transferred where I can get an HDU monitoring. Next slide, please. Hello, are you hearing me?
Yes, please.
Okay, thank you. So This one, let's talk about management of a patient who is having SpO2 below 94. So this patient, we will assume there is hypoxia until proven otherwise, as long as we have pulse oximeter for monitoring. So this patient will be treated with high flow oxygen or hand ventilation if possible. And then you will ask two questions. Is it a patient problem or is it pulse oximeter problem? Of course, if it's a pulse oximeter problem, you will replace your pulse oximeter or you will reposition your probe. So if it's the patient problem, of course, you will support with oxygen, and then we will manage your patient from the primary survey until you resolve the patient condition. It means you need the full assessment while our patient will be on oxygen. Next, please. Next slide. Okay, so let's talk about oxygen delivery device. So when we say oxygen delivery device, we want to say or equipment which are used to administer oxygen to the patient. And here the question, we're asking, how can you select the appropriate device for your patient? So here, of course, the end result of this system is to increase the oxygenation for the patient benefit. Then how to choose it? Of course, you will see the degree of hypoxemia of your patient. As long as you have a pulse oximeter, you can get the severity of hypoxia. Of course, you will need a requirement for precision of delivery. You need or needed materials to administer the oxygen to the patient. Of course, make sure your patient is in a comfortable condition. Of course, don't forget to consider cost for your patient. Here, just about the cost, make sure you are using at the maximum of your available materials in the DH. Let's take the next slide. Okay, by selecting your equipment, here we have some 3 P's principle. So the first one is a purpose. So the purpose of giving oxygen to a patient is to improve oxygenation. It means improve arterial hypoxemia. So the second one is your patient. As I told before, you need to consider the severity of that hypoxemia. Make sure your patient is conscious or not conscious before choosing a device, because some device can't be used in a patient who is unconscious. So make sure you have the age group of your patient, as long as those devices are different from adult, young child, and the adult and the old people. Of course, the last one will be the performance goal. So this means you need to be able to use your equipment you have to meet your patient needs. Let's go on the next slide. Next, please. Okay, so let's talk more on okay. Let's talk more on this table. Here, I want to emphasize on level of oxygenation and intervention which can be done. During oxygenation, we have a 3 categories of patients. So the first category is those a team of patients who are having who need a supplemental oxygen, and this can be sufficient to collect hypoxia. So those patients are somehow really stable and are having a spontaneous breathing. We call them low dependency team. So low dependency team, the patients are coming at you with hypoxia, you give the oxygen, and immediately the SpO2 become above 90. So the second one is the medium dependency. So those are a team of patients who are having a spontaneous breathing, but they need some support, especially a pressure support. For example, in case of CPAP, I think everyone here know what is a CPAP. So those people, they need a supplemental oxygen and a degree of respiratory assistance sometimes. So the last group, called high dependency. So this is a patient who don't have any spontaneous respiration. So it means they need any respiratory full respiratory support. For example, can be intubated, or they will need non-invasive pressure ventilation like a BiPAP. So, and those, they will need supplemental oxygen and respiratory support. So in summary, this is the group. The first one, the patient who needs oxygen and immediately they can be collected. Otherwise, they will need the additional support. And the last one, they will need no respiration at all. Then we manage those patients appropriately. So let's go on the next slide, please. So still on our device, we have 2 kinds of device. The first one is the equipment which can deliver raw flow oxygen. Another one is devices which can administer high flow oxygen. So for low flow, so you know the old device we have in the hospital who can administer oxygen for below 15 liters per minute. Another one for high flow, who can administer more than 15 liters, 20, even 100%. Those are called high flow. I thought you know the difference. So for this raw flow, this is our patient on raw flow are uncomfortable. Just you apply a simple mask or mask of reservoir or nasal cannula, and the patient is stable with that. So, but with high flow, because there is a kind of pressure on the patient airway. So this is really uncomfortable for our patients. And this high flow, another thing I can say is delivering a precise and constant oxygen. But this raw flow, it can't give a precise oxygen. It means if this raw flow device, it's changing based on the patient respiratory rate, the patient stress. So you can't estimate really which flow you are giving and which flow the patient is really receiving. It's not a constant. But in the case of high flow, because you are sure you are applying another force, another pressure, the patient is receiving a precise and constant FiO2. Next, please. Next. Okay, so for raw flow system, I think we are familiar with those devices. The first one is a nasal cannula, which is common in our settings. The second one, which is common in our settings, is a simple facial mask. You can see the image below. And another one is a non-breathing mask, which is having a mask with reservoir bag, you know. I think those kind of three low flow systems are available in our settings. Of course, I'm Masashibe, but I'm sure in DH, you have all of those materials: nasal cannula, facial mask, and mask with reservoir. Next. So for high flow device, here what is familiar with us? The first one is high flow nasal cannula, especially those who are rotating, working in neonatology. I think you are familiar with this high flow nasal cannula. It's really most serving the neonatal patient with respiratory distress syndrome. Another one is a venturi mask. So this venturi mask probably is not available in DH, but later on we will see how to use it. Another one is the oxygen blender. So you know the blender is a machine who's mixing air, so we see in the taste later. So continue. Next. So let's start by a nasal cannula. So as you see the image, this device, I think everyone is familiar with this one. So what I want to tell you. So this one is administered oxygen between 1 to 5 liters per minute. And we expect the FiO2 of 24% to 40%. So please, before in front of your patient, don't give oxygen nasal cannula and set 10 liters by minute. That will be, we will not help our patient. Of course, as long as on nasal cannula you increase the 4% of your oxygen flow, it will increase each liter of oxygen delivery. So for example, if you are at 4%, a flow of 4 liters per minute, and you increase it from 4, you go to 5. Immediately on the patient FiO2, it will move from 4, maybe it will be add another 4. If you were at 25, for example, you will reach at 29 or 30. So next slide. Next. So advantage of a nasal cannula, of course, it's used ideally for long-term oxygen therapy. Of course, it doesn't need humidifier, of course, of low cost. Of course, it's helping patient are comfortable by having a nasal cannula. You can speak, you can eat, even you can drink. So one of the disadvantages of a nasal cannula, so it can't provide the high flow. Another one, it can make irritations of airways membrane. And as I told before, the FiO2 by a nasal cannula will vary depending on the patient respiratory effort. So when you put a patient on high flow, on high flow by using a nasal cannula, for sure it will be an uncomfortable patient. We'll see later. So next slide. So let's talk about a simple facial mask. Also, I know every DH, every medical staff, nurse, whatever, is familiar with this mask. What I want you to know is so that it can administer oxygen between 5 to 10 liters by minute. And you expect your FiO2 to range between 35 to 55%. So really, this is commonly used in our settings. So I don't dwell on it. Let's go to the next slide, and we see an advantage of this simple facial mask. Of course, it's less expensive and it can be used in mouth breathers, especially those patients who are developing obstructed nose, maybe by upper respiratory tract infections and whatever. This is very, very helpful. Of course, as a disadvantage, this is very uncomfortable. Of course, it requires a tight seal. Make sure you are covering the patient nose and mouth. Of course, it can administer, it can't deliver high FiO2. Then also FiO2 will vary depending on the patient respiratory effort. So it's not very easy to eat or drink or to communicate by having a simple facial mask. So of course, it's really difficult to keep it for longer times. And let's go on the next slide, please. Next.
I think Dr. Joseph are there. I think he lost the connectivity. Dr. Poiner, can you continue by supporting him while we're waiting him to come back? Dr. Poiner? Okay, Dr. Joseph was talking about oxygen delivery devices, low flow devices. He was on non-breather mask. He was talking about the indication of this non-breather mask. Aponer, are you around? Okay, this non-breather mask will be as we are escalating by providing oxygen according to the 3 Ps we discussed about to the patient in needs. It will be when the patient will need oxygen supply at high rate or high flow, and also will be in case also this will be achieved while we are giving appropriate and adequate flow rates. As we said, we are having non-breather mask, which we may be using to 15 liters, as he said. So there is advantages and also there is disadvantages. The most advantages is this: when you use the non-rebreather mask, you may prevent some unnecessary intubation. So here we give a message to the hospitals to have all these necessary equipment so that they are not unnecessary invasive ventilations. Disadvantages that not suitable for long term. You know, our patients in this time of COVID, we are having them on high flow oxygen more than the one we should be providing. We are in 60s, 70s. So is not suitable for this long-term use. But also when it's malfunctioning, it can cause CO2 building up. Here, I want to emphasize on the, can you be next, please? Next, no, the previous slide, Yes, I want to emphasize on the this non-rebreather mask. As you see, we are having the inspiratory one-way wave, and also we are having the 2 expiratory one-way waves. In most of visited the health facilities, we are finding them closing this one-way valves of expiration. Please, when you close this expired one-way valve, you are making the patient to rebreathe the CO2. So you have to check whether your non-rebreather mask has these 3 valves: this expired gas one-way valve, and also the 2 expired gas one-way valves. Otherwise, you are using an inappropriate so-called non-rebreather mask. So here, please don't close those wave valves, and make sure that inspired wave valves in the non-rebreather with the reservoir is functional. Some of them, they are not in, and they are making your patients uncomfortable than helping. So the message here is to know the physiology, the physiology of this non-rebreather mask with the importance of these valves in it. Next, please. Next. After talking the three routine used low flow oxygen delivery devices, we are going to discuss about high flow oxygen delivery devices like Venturi mask. The Venturi mask, I found them in some of hospitals in our country, but not really used. They was in the stock. They don't know maybe what they serve for. But I hope from this presentation, you want to go to see if you have them and use them because of its appropriate. It is a high flow device and is using a precise measurement, and we deliver a constant FiO2 we need, as we discussed in the previous presentation, in between the difference between low flow and high flow delivery devices, the difference there. And also you can use this to deliver a flow to 24 to 50% of FiO2 using less liters of the oxygen delivered. So from this, then you are also not wasting oxygen, and you may have less costs by using it. So we need it when we need it to give more FiO2 with precise and constant oxygen. Next, please. As we said, with others high flow devices, is it controlled FiO2, is it fixed, reliable, and precise FiO2. And also the high flow comes from the air. It's not the same like the others we are having coming from other, and may save the oxygen cost, as I was saying into the previous slide. But the disadvantage is it uncomfortable, somehow expensive, is not like those simple masks you are using. And also the one thing, as other masks, it can interfere with eating and drinking and make it uncomfortable patients for that. Next, please. This is high flow nasal cannula, also called high flow oxygen therapy. As you see, in COVID centers, here in Rwanda, we have this machine, or we have this device used when we failed from the non-rebreather mask and we want to escalate to the high flow, but is less used, maybe because it's not really the routine in our practices. But I encourage you, if you have it, to use it, because it will help us to help our patients, making them more comfortable than uncomfortable by the low flow oxygen delivery devices by using high concentration oxygen, as we do when you give more than 15 liters on a rebreather mask, whether you should need to use either the Venturi or this high flow oxygen therapy. This high flow oxygen may wash out the carbon dioxide in anatomical dead space, which may be retained there, and also create a positive pressure. As you know, we talk about a positive pressure when we say patient is on the machine. It's the same as the machine, but also by creating this positive pressure, you may regulate the FiO2 you need, and also the FiO2 will be constant. As we said, is the same for all high flow oxygen delivery devices. The patient may be sitting and you deliver the oxygen like this without intubating. Is humidified and also is warm oxygen, which helps the patient to they are comfortable than using those facial masks as we use them. Next, please. There is another thing you have to think about. After COVID recovery, we may have this long-term oxygen delivery. I think to this time, we are not yet having this reservoir nasal cannula. And we want you, by knowing is needed, you may in your supply, in your procurement plan, you may think about what you will be needing to help our patient we are saving in our remote area where we work. It has a gas supply. You may have oxygen concentrators, which are not easy to afford, can have compressed gas or liquid oxygen, and also delivery devices for long-term oxygen therapy, which include, as we said, the low flow devices, as you see on this image, like reservoir nasocannula. So from the procurement plan, please think about this, all things we are talking about, so that we hope we will be managing our patients by non-invasive measures, and we give them oxygen they need to correct the hypoxemia as we are discussing to this time. Next, please. There is a blending system. This is a blending system. I'm not going to talk much. I want the IT to help us to watch this video of 1 or 2 minutes. And you see this blender system is used, and we may think about if we will need it in our procurement plan to bring it into our treatment devices we have in Rwanda sooner or later, by knowing how important it is. That is the aim of this talk now, as we're talking about oxygen cylinders in critical care. Please, can you play this video for like 1 or 2 minutes?
The oxygen blender is used to deliver an exact FiO2 to our neonatal patients. The purpose of providing an exact FiO2 is to minimize the complications associated with oxygen therapy. The more commonly known conditions are ROP, retinopathy of prematurity, and BPD, which is bronchopulmonary dysplasia. The way that these blenders work, we have a flow meter that's attached, which we will give our liter flow, but to control the FiO2, we will actually adjust the dial. The dial on both of these blenders goes from 21% all the way to 100% with various stopping points in between. So that is how we're able to give a direct FiO2. To use the blender, you have to plug in the cables. We have oxygen and air. We plug them into the wall, and you'll notice that when I plug in one gas source, that you're going to hear a high-pitched sound. That is an internal alarm for the blender to make sure, or to let the clinician know, that either a hose is disconnected or the tanks or gas source needs to be changed. So here is our loud pitch noise. And so if you hear this noise, that means that there's a disconnection or the tanks are empty. In order to turn this off, just plug in the other hose, like so. Once both gas sources are connected, then the blender stops its high-pitched alarm. In order to use your blender, you can still attach a water bottle if necessary, or your Christmas tree attachment if necessary. And you would just connect it to the flow meter like so. So we will say that our patient is on a 2-liter nasal cannula. We adjust our flow meter appropriately. There we go. So we have our 2-liter flow coming through the flow meter. Currently, our patient is receiving 40% oxygen because that is what we have our dial turned on. If we want 21%, we turn it there. Or if we want to go to 100%, then we can go there. So the blender just allows us to give an exact FiO2 to our patients. That's it.
Yes, just that was to show to the audience oxygen blender, which can give oxygen ranging from 21 to 100%. And just to show you that there are some devices we may not have in our settings, but we may, by our procurement, have them sooner or later by knowing how important they are in helping our patients in critical care management. I think Dr. Joseph is back. Dr. Joseph, take the ball to you and continue our presentation as we are waiting our audience for the questions. Thank you. Dr. Joseph? Dr. Joseph? Joseph, are you back? So while we are still waiting him to come, let me continue by telling you all those delivering that oxygen using either low or high flow oxygen devices. You may need the humidification or humidifier just to now nasocannula oxygen delivery. As we are less than 5 liters, we may use or not use the humidifier. It's not that need than when we need it to be more than 6 liters. So the humidification, just you connect it to the flow to moisten the oxygen so that the patient's airways are not in discomfort also, or there is no traumatic irritating oxygen. It's very useful in long-term use oxygen, or when we are using a high amount of oxygen is required in the case. So think about this. Don't put a patient on a machine without water for humidification. And also when you are using high flow, please think about humidifying your oxygen. Next, please. So where do we get that oxygen we are delivering to the patients? That is a question I'm sending to the audience. You think about them. Think about Rumea, think about photosynthesis. And by the two sources of oxygen, we may think about our environment and try to protect it. In our environment, we are having a 21% of oxygen, and from which we may have oxygen saturation of 90 to 95 to 100 on room air without any other supplements. But when we are not able to use that oxygen by different mechanisms, so we need to supplement. That is one of the oxygen sources. Please. Second, oxygen source or oxygen supply you have to deliver the oxygen by the oxygen delivery, we said, there is the concentrators. There is the concentrators, but also there is oxygen plants. So we are having from the nature, from the environment, the oxygen, or from the photosynthesis. But also we may have these concentrators or oxygen plants, which I think we are having most of our referral hospitals, like our Nyarugen COVID Treatment Center, which is now closed to other settings because there is no more that much number of COVID cases. But we still have oxygen plant to deliver to the patient who will need it in other critical conditions other than COVID. I think in some of your hospital or health facilities also you may have it. But if you don't have either concentrator or oxygen plant, you may have, next please, oxygen storage system, which I think most of us in our hospital, health centers, or wherever, we are having cylinders. This is a photo of one of our health facility. They have these cylinders, but also they have this bulk tank. If you are not familiar with them, please try to visit some hospital and be familiar of what you may need to help our patients getting oxygen as you have to give to them. Next, please. Yes, this is like, as I said in our objectives, it's like an assignment to every one of you to go back to your hospital or your health facility and you assess non-invasive oxygen delivery devices you may have to now. And also think about what you may have, but you don't have from this talk we had now, from the low flow oxygen to the high flow oxygen. And so I think you will have good equipment to your hospital. Once one of our beloved patient comes, I mean, every patient is our beloved, you will be able to manage him without sweating because you don't have an appropriate non-invasive oxygen delivery devices to use. The second thing I want you to do is like to assess your facility's type of oxygen supply available there. And by so, you will say that nearby my health facility, I may have the oxygen plant, I may have the bulk tank. You may go and then you take it to your cylinders, but please don't have like stock out of the oxygen. Otherwise, your patient will be have a poor outcome, as we said, how bad the hypoxemia it is. So this is from the general topic. I was just taking over because of our colleague, Dr. Joseph, lost the connectivity. Is to you, please, the audience, time of
maybe there is no question for the audience, but I want to make like some comment on how we use the oxygen in our different settings. We saw that there is a misuse, and then you know that in our most remote areas, the oxygen is like very expensive. You know, for example, someone from Nyanza, the oxygen is from Butare. Meaning that if you are misusing, if you are giving like 10 liters on a nasal cannula, think that you are spending oxygen. Also, I want to remind, if you give someone oxygen and you start by 5 liters, if you find that there is improvement on oxygenation and you see that the saturation is like 99 or 98, you may titrate and reduce at 4 liters. If tolerating, you reduce again at 3 liters, like weaning process on that oxygen. Yeah, remember to maximize like our care to the patient, and remember to wean on time the patient. Thank you.
Thank you, Aponeri. While you still have your time, can you help me answer this question in the chat? What could happen if you are giving oxygen with mask and reservoir by giving like 5 liters?
Okay, that's a good question from like the audience. I think it's Kanyamingo who is asking the question. If you give mask with reservoir 7 liters, you know the reservoir have to fill in full. If the reservoir is not full, the patient, you know, the oxygen will not arrive at the patient, meaning that the 7 liters will be not too much to fill the bag, so that the reservoir, so that when the patient is like breathing, he's breathing only, he's not breathing like the maximum of oxygen he has, because much oxygen is going to the reservoir instead of going to the patient.
Yeah, thank you for that answer. Just some addition.
So I have a
Dr.
comment.
Dr. Kanyamihigo, who asked this good question, I really want to emphasize. You see, as we saw the physiognomy of the non-rebreather mask or facial mask with reservoir, they have this oxygen gas valve and also exhalation valves. If you give this less liters, that valve will still closed because there is no pressure to help the patient inhaling it. And at that time, you will see most of these patients who are having this facial mask with reservoir, but which is not full, as Dr. Paul was saying. These people will start to sweat because of what the CO2 will be much concentrated in the mask, and they're not receiving the oxygen because you give less, so that they are not really giving appropriate as you should. From this, you are not helping the patients. You have to think when to use facial mask with reservoir and when not to use it. And when you need it, please give an appropriate oxygen. There is another question. The non-rebreather mask has one-way valve. You want to avoid the mixture. Thank you, Dr. Venus. That is nice. Thank you.
All right.
Any other question?
So let's answer. Yes, of course. I apologize for network issues. Of course, I'm not an IT. It was really difficult to use the line to get back. So it's happened, of course. So let's discuss a little bit on this assessment of the facility for non-invasive oxygen delivery device. Yeah, of course, really, especially in this hospital, we have those materials and probably are not well used. So I think after this presentation, we will start to go to patient receiving oxygen really by using a proper device. Really, I can't imagine how I can feed with a pediatric spoon as a mature person. Really, so that you could compare this as oxygen delivery device. So if you give someone with a small device, if you require a lot, for really it's uncomfortable and you're not helping a lot. Of course, don't take a small people and then give oxygen by using a huge materials. Then you compare it like feeding a neonate by a big spoon. Please, I know we can list them what we have. So I don't know if it's someone from maybe, if possible, you can get suffer at least 5 minutes to hear someone today who is currently working in this hospital. I can see here with people, so maybe they can give us a small experience how they're using oxygen and how they're going to be collected as the purpose of this presentation. I can see other people from Gitwale here, some from Gonero, from Kibuye. I can see Nyanza around me. I see someone Kabutare. So there maybe someone at DH can give you a short experience so that you can see at least a list of those devices which are there. I think we have.
Before you share the experience, in the chat, you have a question. You have to make some comment on it. By the time I would like to ask about non-rebreather mask, some people in COVID-19 used to cover expiration valve, which are located on two sides of the mask, saying that easy to prevent a wastage of oxygen delivery. And in our presentation, it was said that we are not allowed to close them. Do you have any comment on this? Can you explain to me more the disadvantage of closing them physiologically? And thanks. Joseph?
Hello?
Yeah, there is a question, there is a comment in the
Yeah,
chat.
okay. Are you hearing me? So for this is a wonderful question. So I don't know if those people who was wearing those masks and cross them really did understood the reality of those masks. Yeah, it is not a wastage of oxygen delivery. So we don't need to close. We don't need to close as I made like as Venuste said before. Those non-breather mask, they have one-way valve. So if you close it, you change nothing if you close it. Just you maybe are doing with aesthetics, but if you close it, allow regarding the oxygen delivery, nothing is changing. That's my short answer.
Maybe if you are hearing me, I can say something.
Yes, we are hearing you, Olivier.
My question clearly was not to think economically the importance of delivering oxygen to the patient. It is that Dr. Xavier was saying on those two valves, which are on the nose, to that non-rebreather mask. He was saying that to close them is to prevent CO2 from being expired outside. And I have seen some used to cover them, the two sides with adhesive plaster or sparadrap. I have been confused if it is really to give the huge amount of oxygen to the patient, or it can later aggravate the situation by reconsuming CO2, not letting it out. That was my question, confusion, in other words.
A good question, by the way. So, as we say, the physiognomy of that non-rebreather mask, you don't have to close it. As we are discussing on this session, when you close it, you are making CO2 return into that closed space. And also the oxygen which is coming to the patients will be mixed in there. So as it has been designed, let the oxygen during the inhalation goes into the patient through via the inhalation valve. And when there is expiration, you will see it, the inhalation valve will close and those exhalation valves has to open. So leave them like that and make sure there are also some non-rebreather masks which are not having those valves because they removed the two valves, and make sure those valves are there. Otherwise, the device you are using is not appropriate. The way you are practicing today is change our practice in a proper way to give oxygen to our patients, I think.
Yeah, sure.
Thank you for the good question.
You're welcome.
Yeah, as Dr. Joseph was saying, any comment or experience sharing from the audience, how you routinely use to give oxygen by oxygen delivery device you are using, or by which means, please 2 minutes to share your experience with us before we close.
So even there are French people here, just feel free to ask a question in French or give it.
Even in Rwanda, we will interpret. We want people to feel free and interactive.
Yeah. So, probablement, pas d'intervention, pas d'autres questions, probablement.
So, nous pensons que peut-être il n'y a pas de questions qu'on déjà peuvent avoir en Kinyarwanda, en français, en anglais ou en swahili. Yeah.
Mwiriwe neza.
Twagusuhuje, wiriwe.
Guturuka ku Kibuye. Najya mbaze aha abandi aho bakoreye wenda bafite ibikoresho byisumbuyeho. Hari abafite CPAP z'abantu bakuru?
Yego zirahari.
Zaba ziboneka hehe? Zirakoreshwa?
CPAP z'abantu bakuru so nkanjye ndi sashipe zirahari, n'amasosiyete zirahari, abantu bari Nyarugenge numva bazifite, so abantu bari mu Ruhango Ikinazi baretse kumbwira ko nabo bashobora kuba bazifite, so normally doctor ibikoresho birahari, ahubwo kuko abantu tutazi igihe bikoreshwa nuko bikoreshwa, hopitali irabigura ugasanga biri muri stock. So ubona ngo turi kuri this device nk'ubu usanga ama-DH menshi abantu bafite za ventilator machine zibitse batazi ko zinahari. Hanyuma nabaye ku munini namaze imyaka 2 ako navuye ntazi ko ari ventilator 3 ventilator machine. Nabimenye ariko ntangiye kwiga residence ubwo byanabaye ku munini byari ventilator machine. Nta muntu n'umwe wazi ko dufite ventilator machine ari. Ngango ushobora gusanga ibintu biba bihari ngo tutazi kubikoresha. Iyo utazi gukoresha ikintu ntabwo wamenya ko kinabaho. Ariko CPAP machine CPAP za facial mask za CPAP zirahari, ndakeka no mu isoko i Kigali muri za Kifarma wasanga zibamo, kuko ntabwo bihenze, ndakeka na hopitali zikeneye yazibona, especially nk'abantu bakoze muri covid. Murabizi ko presque ahantu hose zari zihari mu masantre ya covid ndetse nyinshi cyane.
Thank you. Any other question? Autre question? Okay, we are running over time, but I'm really very happy to hear the experience and the good questions on this platform, on this session. Can you please have a take-home message from our talk? Next, please. I don't see slides. Yes, I think from our discussion, we have already our take-home message. Our take-home message is go back to our respective health facilities and change practices in knowing how to use a pulse oximeter in oximetry, and also understand how the pulse oximeter is being used, when, how, and what are the interference, and what are also limitation of the pulse oximeter. And from here, don't just report the number you are reading. Take your time to place the pulse oximeter in the right place, and then read the screen by looking the three things. If not there, you have to say that your reading is not accurate. So you have to see if there is that waveform in a good number and the pass rate, and also go home by knowing how to use oxygen delivery devices from the low flow oxygen to high flow, and know when to give how many liters, to avoid one the cost for nothing, or also to want to keep to be economists, and then you are not helping a patient, like using facial mask with the reservoir in low amount of flow, less than 10 liters, as we discussed. Be able to use the LifeBox triage tool, as you see, by considering the symptoms and the emergent signs. You may know which kind of devices you can use in escalating that, and also know how to clean the pulse oximeter. And by now, our assignment is like to assess in our facility these oxygen delivery devices we are having, and the source of oxygen we are delivering to the patients we are treating. That is like our take-home message from this talk. And before we close from the communique from our partners in India on Stanford, I want to thank you for your kind attention, and also to inform you that we are having this course on oxygen and critical care management. It is a 12-session course, which we are holding every two sessions per month, and we will hold it into 6 months now from the last time to, I think, in March next year. And we will provide a certificate from those different partners, Stanford or Project ECHO, and our hub itself. And also by those kind of certificates, we're also having corresponding credit so that you can go and renew the license like critical care providers in different and remote areas, while you know all things we are discussing to this time. And hope not just waiting those, go and change practices of what we are talking. Other thing is to let you know that the next session is on November 17, 2021. We'll be talking about escalation to a higher level of care. So as you remember from the triage, today we talked about, we detect there is hypoxemia by our means, and we try to treat by giving oxygen with different devices on different flow of oxygen we're having. But if you still fail helping your patients, when to do escalation of care to a higher level care we'll have. I think from me is that announcement, but from our partners in Stanford, Assistant International or in India, please, time is up to you for your comment and some communicate to our audience.
Thank you very much, Dr. Zaiva. Thank you all the panelists. It was a great session. And then, like Doctor has rightly said, our next session is on the 17th of November. That will be the session 3. I've put the email in the chat box. If you have questions, after now you have a question you want to ask, please feel free to send us an email I've shared the email on the chat box. And then if you want to join our WhatsApp community, the number is on the screen. Please indicate your phone number via the mail, and we can add it to our WhatsApp community. Like he rightly said, the resources from the Learning Resource Center, the link is also shared. Feel free to register freely and visit the center freely and register freely so that you can have access to the resources outside the training. Thank you so much. Please share the word with your colleagues and then other medical personnel that you know that this will benefit. Share the word with them, and then see you next time. Thank you so much.
Before you close, there is this communication from Ala, now from you. So just to clarify things, from this course, we provide certificate of attendance, but also with the corresponding 30 CPD points, which will be assigned to people who attended 75% of live session or more. So we need you to be participants to get this good certificate on critical care and oxygen therapy during our 12 successive sessions. I think that is what I want to clarify to the audience. And please keep inviting other people. We are still registering. We are still need people to come and attend our course. as more as we can. Registration is still going on. I think, thank you for your attention, and see you next on 17th, 2021, talking about escalation of care. Thank you.
Thank you.